Good morning, everyone. I'm pleased to welcome you to the Department of Medicine Grand Rounds this morning. I'm Jennifer Cook, the Vice Chair for Faculty Affairs, standing in for Dr. Williams, who is in Australia at the moment. And I'm very pleased to be able to introduce our speaker today, Dr. Robert Friedland. Dr. Friedland is helping us carry on a tradition today in the Department of Medicine, whereby for at least the last decade and a half, perhaps longer, we have reserved a yearly Grand Rounds spot for our colleagues in neurology. As of course, internists and neurologists are sort of extensions of each other when it comes to treating our patients. So we're very happy to have him here today. Dr. Friedland has been with UofL since I believe 2008. And he is the Mason C. and Mary D. Rudd Chair and Professor in the Department of Neurology. He specializes in behavioral and geriatric neurology and is chief of the Laboratory of Neurogeriatrics here at University of Louisville. I could take all morning to tell you about his over 200 publications and 300 presentations, but I won't, so that we can get started. And I'm so pleased to see that Dr. Friedland, who is definitely an outstanding clinician scientist, also holds dear his role as clinician educator. And he is going to be talking with us this morning about teaching critical thinking to young doctors. So Dr. Friedland, welcome, and I'll turn things over to you.
Thank you very much, Jennifer. I'm pleased to talk to you about the need for education in critical thinking and my approach about how to do it. But before I do that, I want to present a little follow-up. 1 year ago, I gave a talk about the theory of multiple reserves. Just to discuss, this was based on the idea that aging is not inevitable. Because it's not inevitable, it's an opportunity. And we can consider human evolution, which helps us decide what to do with aging. And that we need to have 3 goals in aging, not only survival and not being sick, but being fit. And this regards our capacity for paying attention to what we do and what attitude we have, and realizing that aging is an opportunity which is not available to everybody is critical. And I've discussed and presented all these factors in this book, which was published in October, which is entitled On Aging, the 4 factors, in which I present in detail the 4 multiple reserve factors which are involved in aging and what you can do about it, what we can all do about it. So I have a thought experiment, and actually several thought experiments. My book really was based on the thought experiment of what do I do with a patient who wants to know what they can do to age well, not necessarily an Alzheimer's patient, just an older person or middle-aged person who wants to know what they can do to age well. And I have 100 hours available to tell them. That produced my first book there on aging. Of course, it doesn't happen. You don't get 100 hours to talk to somebody, but if you write a book, you can do the same thing. The other thought experiment is something that happens to all of us in teaching. We have a medical student comes to the clinic, and I have them for 1 day. And I think, okay, what am I going to do with them for 1 day? Am I going to just let them watch me? Similarly, when I was chairman of neurology and arrived here in 2008, I found this monthly assortment of medical students that come on a neurology clerkship. And I had a 1-hour lecture on Introduction to Neurology. What am I going to tell them that they can't learn in a book, or they won't learn from somebody else? 1 hour obviously is not enough to teach them neurology. So whatever I should be teaching them should be important and something they can't learn otherwise. This led me to this idea about having lessons in critical thinking for young doctors, not necessarily only for young doctors, but perhaps focused on young doctors and what they need to know, which would include graduate students, postdoctoral fellows, dentists, nurse practitioners, physicians, residents, medical students, and so on. Critical thinking is defined by the Cambridge Dictionary as a rigorous type of thinking that involves making fair and careful judgments based on evidence, reason, and open-mindedness. And the important concept for me is to be aware of thinking, not to take thinking for granted. Of course, when we walk, we can take our flexion extension at the knee for granted. We don't have to pay attention to how the knees are flexing and extending when we walk and how we shift our weight from one leg to the other. That's automatic, and it's supposed to be automatic. If it wasn't automatic, probably we'd all fall down. But thinking also works automatically. And in order to think well or to think deeply, we need to pay attention to this. So imagine here, this is lesson 1, which I call Think Deeply. The patient is a 74-year-old alcoholic hypertensive man who smokes. He has a left middle cerebral artery thrombosis and a stroke. Of course, alcohol, hypertension, and age and smoking are all risk factors for stroke. So if I ask, why did he have a stroke? I'm sure most, even neurologists, would say, well, that's clear. He's alcoholic, hypertensive, and aged, and he smokes. What if I said his brother was 78, and he also smoked and had hypertension and also drank too much, and he never had a stroke? How could that be possible if this man's stroke was caused by these risk factors? The idea of this thought process is that we don't know why people have strokes. It's not enough to attribute disease to risk factors, because risk factors are not causative. It means we need to find out other things that might be involved. We need to do more work on it. We shouldn't rest upon our knowledge that we know about these risk factors, because that's not enough. A similar question here is, why did it affect his left middle cerebral and not his right? What could possibly be involved in that? How about this question? Why does ALS, a motor neuron disease, amyotrophic lateral sclerosis, it always begins with focal deficit. It doesn't begin everywhere at the same time. Patient might have a weakness in the foot as the first symptom. Another problem might have a problem with slurred speech. If you ask a neurologist why, they'll say, oh, I know. They'll say, this is the different part of the nervous system which is being affected. And that's correct. But that doesn't explain why. So if we ask why, we can look for a theory. And I've discussed this with many people. As far as I know, there isn't any theory except my theory, which is this is where the microbiota, or the gut bacteria and fungi and microbes, are interacting with the nervous system. And this is a long discussion we could have about that possibility. But I am very excited by the idea that I have a theory about how that happens, and that there's evidence to suggest is correct. So that if the bacteria in the colon are interacting with the spinal cord, you could have a problem in your feet. If the first problem is an interaction of the bacteria in your mouth, it could affect the brainstem first and cause bulbar ALS. Another and similar question about thinking deeply is a 72-year-old woman who has Alzheimer's disease. And for some reason, somebody, not me, but somebody tested her apolipoprotein E4 genotype. And she had 2 alleles of E4. I'm sure many Alzheimer's specialists would say, oh, she has Alzheimer's because she has 2 E4. However, many Alzheimer patients do not have E4. Many people as many as 40% of people at age 80 who are homozygous for E4, who have two of these alleles, do not have dementia. This shows that E4 is not the cause of the disease. It's a risk factor. We still have to figure out what is the cause. It is a false certainty to attribute a risk factor to being the cause of the disease. And if I could move some things aside. Lesson number 2. The key factor which determines what we perceive is our attention and how it's focused. So lesson number 1 would be think deeply, and lesson number 2 is how do we pay attention? Also, our attentional capacity is also automatic. When we're driving, we're paying attention to the road and the traffic signs and the little dogs and so on, and that happens automatically. And we don't necessarily have to be aware of it at each moment of how we're focusing our attention. But when we're practicing medicine, we need to pay attention to that. We need to be aware of how we pay attention, because that's the critical factor for critical thinking. And a question here is, do we pay attention to the patient, or do we pay attention to their biomarkers? Do we pay attention to their hemoglobin or their MRI scan, or do we pay attention to what the patient is saying? A rather horrible example of this is illustrated by this FDA commissioner, Janet Woodcock. Last year, she and the FDA approved aducanumab, which is an Alzheimer's drug from Biogen, which has been shown to not influence the cognitive decline in Alzheimer's disease. But she approved it because it improved the biomarker. She said, and this is a quote, fundamentally, at some point, the 50-year investment in basic science has to merge with clinical methodology. And we have to just stop thinking empirical evaluation is the only way of evaluating truth. I hope you're all astounded, shocked, and upset to hear somebody saying in 2021 that we should stop looking for evidence. So they approved the drug because they thought its influence on the biomarker would be valuable, but they didn't. The study showed that it wasn't. This is the most widely criticized FDA decision in history, and it's been condemned by several organizations and institutions. And the drug is now the most unsuccessful drug launch in American history. So now for lesson number 3, what could I possibly mean about these dolphin B? And my point here for lesson 3 is we do not perceive the world the way it really is. This is also related, of course, to attention and thinking deeply. So many of these lessons are can be interacting, but we can't use sonar to tell if a friend of ours has a lot of gas in their stomach, like a mother dolphin can tell if a baby dolphin needs to be burped. With sonar, we can't do that. Bees can perceive the electric field of flowers. I can't do that. And of course, bats can fly in the dark. And I don't have sonar. I can't find my way around in a recreational activity that would create this problem. The last thing I did, just as he was out the door, I said, "Pardon me, could you tell me if you have any idea what is going on?" And he told me that he liked to play a video game which involves pushing his right thumb, the base of his right thumb, into the video game console and rolling a little ball. And he was playing it for hours every day. I said, "Well, stop doing that." So I discovered the cause of his problem. And actually, with my colleague, I published this case in the New England Journal. It was called video game palsy. 1985. I had a 35-year-old man who had a radiculopathy on the right, and I didn't know why. I did appropriate tests, and I couldn't explain it. And I asked him also at the last possible moment, could he please tell me if he has any theory of why he has this? He said, well, maybe it's because of this yoga position where I stand on my head. And he showed me how he stands on his head with his neck bent. And I said, don't do that. And when he stopped, he got better. But I wouldn't have known if I hadn't asked him, because listening to the patient is the critical factor, which is getting harder to do these days. Another factor about this teaching critical thinking is we have to remember these great figures in the history of medicine. And it's disturbing that my experience with medical students is many of them never heard of William Osler. They never heard of Albert Schweitzer. Some of them even don't know who Louis Pasteur was. And it's interesting to remember even William Osler, in his book about student life, recommended every doctor to have every student to have a little book that they carry around with them all the time. And I think that's a wonderful idea. And I recommend it and often give little books out to students who don't have little books so they can keep notes and help to turn their learning into stories. William also said, she who studies medicine without books sails an uncharted sea, but she who studies medicine without patients does not go to sea at all. That's a misspelling of the word sea there. So this is lesson 4. The patient is trying to tell you the diagnosis. This is because the disease is common. It's the patient which is unique. This is a quote from Rabbi Abraham Joshua Heschel. Finally, about lesson 4, if we're going to pay attention to the patient, we should be practicing deep listening, which is when we're listening and only listening. We're not preparing. I'm embarrassed to say I've had patients where I'll ask, how are you related to the patient? And the woman will say, I'm his sister. And then I ask the patient, do you have any brothers and sisters? As the next step. It's necessary we listen to understand, not only listening to reply. What possibly could Christopher Columbus and Post-it notes have in common? I'm sorry that we're not all in the same room, so I can ask for volunteers to answer this question. But according to great French physiologist Claude Bernard, theories are not true or false. They are fertile or sterile. So Claude Bernard was another figure which students have to know about him. He developed the idea of the milieu interior, which became homeostasis. And he has a wonderful book, 1865, Introduction to Experimental Medicine, which of course I read in English and is available from Dover for about, I don't know, $6. And it's a magnificent discussion of thinking. He discovered the role of the liver in glucose homeostasis. But to get back to the Post-it notes, Columbus said we could get to India by going west from Spain. And he was wrong, but it was a fertile idea. And Post-it notes were developed in an effort to get a new glue. The new glue was a complete failure because it's very weak. It doesn't hold much together with much force. However, because it's not very powerful, it's used for Post-it notes, which is the largest product of the 3M company. So theories are not true or false. They are fertile or sterile, which applies also to our patient care. So if you have an idea about a patient and you think, well, maybe it's this, maybe it's that, and it turns out to be wrong, that doesn't mean that it was a mistake. Whatever you develop, you may learn something very interesting, which could be very important, even though it's wrong. imagine here, lesson 6. A 34-year-old woman had a headache and blurred vision. She was admitted to the hospital. This is when I was at Mount Sinai in New York City, a neurology resident. We go to see the woman with the chair. And the woman, she had an angiogram in the morning. She said to the chair, please have a seat. And she had prepared a seat for him by the side of her bed. And he said, no, that's okay. I don't need to sit down. And he put his arm on her shoulder and he said, your angiogram showed that you have a brain tumor and the neurosurgeon will be here in the afternoon. And she started to cry. What do you think he did? He left. He took all the residents out with him, students out in the hall. And then he said, notice the pseudobulbar palsy, meaning that she was crying because she had emotional incontinence because of a frontal lobe damage. When the truth was, she was crying because she's a human being and she was just given rather horrible news. He violated the rule of you must give bad news sitting down. By refusing to accept her offer of a chair, he was being extraordinarily cold and cruel, demonstrating his inability to deal with the emotional nature of this interaction. This is called intellectualization. Intellectualization is when you allow thoughts to prevent you from feeling. And we must avoid this. Using reasoning and logic to avoid uncomfortable or anxiety-provoking emotions. Using thinking to avoid feeling. This is a defense mechanism, which we're all possibly capable of. The truth was the patient was not crying because of pseudobulbar palsy. Lesson 7. This is an incredibly easy question, which are older, stories or books? But I think it's valuable in explaining that stories are part of the brain. The ability to appreciate stories are a function of the brain, and evolution created our nervous system with a capacity for the appreciation of stories. Just like we're capable of thirst, because if we didn't have thirst, we wouldn't have very good water balance, and that would be a big problem. We all, or nearly all, like stories because they help us to survive. 50,000 years ago, assuming we had language at that time, and nobody, of course, nobody knows, but whenever there was language and people were going to transmit information for the past 100,000 years of human evolution, stories was how information was transmitted. Books are only a few hundred years old. And even 100 years ago, most people on Earth were illiterate. So a family of 5 children 10,000 years ago growing up in, let's say, the Middle East or anywhere, Africa, if one of the children didn't like stories because of a genetic inheritance in his brain, he just didn't pay attention to stories, that would be bad for his survival, because he may not remember what the grandfather said to do in the case of drought. Or you could all invent similar scenarios why it's important to pay attention to stories. So this is a feature of the brain. We learn better from stories than from books. Of course, some people can read a book and read a 31-page chapter about the metabolism of calcium in the liver and remember everything they read. But that's not true about me and not true about most people. We learn better when we're learning something from a patient, because each patient is a story. But I believe medical students need to be taught that they need to pay attention to stories and to patients, because it helps their learning. And it's a better way to learn medicine that way than from a book. Which doesn't mean that you don't read books and literature, but you must have a balance. This is lesson 7, that the brain is equipped by evolution for the appreciation and power of stories. And this can be used to enhance our learning. And also, at the same time, we must respect the patient's stories. I was shocked when I went to see many years ago an orthopedist because I had a pain in my ankle. I waited, in a room for an hour and a half. When he showed up, he just grabbed my ankle, poked it, and said, "You need an MRI," and he walked out. And I was shocked and said, "Where are you going? I haven't told you the story of my ankle." This is an important feature of my mobility. I only have 2 ankles. For him, it was another ankle among thousands. But he paid no attention to my story, which is not a good way for me to have a good relationship with him. Stories help us to learn. And each patient has an opportunity to do this. According to the president of the Pasteur Institute in Kyoto, every time I see a new patient, I read a new book. Lesson number 8. This is an important consideration, that rare presentations of common events are more common than common presentations of rare events. If you consider 100,000 people, this should be 100,000 people over 65, there would be 5 to 10,000 who have Alzheimer's disease. How many have Creutzfeldt, Jakob? Less than 1. So that if you're considering a patient who has a certain scenario of diagnostic features, if it doesn't fit something which is common, it may be that it's more likely to be a rare version of a common disease than a common version of a rare disease. Lesson 9, words influence thought. This is the Sapir-Whorf theory of language. These are 2 linguists from the 30s, maybe 20s, who said words control language, words determine meaning. This theory is not very popular nowadays, but it undoubtedly has a large element of truth. That is, the words we use influence how we think. So my favorite example here is rule out. We should never say rule out, because rule out means that a possibility has been eliminated. So I'm showing the elephant because if you assume that I'm in a room and we're all attending medicine grand rounds as it was done in the old days, in the basement of the hospital and so on. If I was asked, is there an elephant? I can look for it. I can smell it. I can go onto the desk. I can say, there is no elephant in this room. I have ruled out the possibility. I have eliminated the possibility that there's an elephant. The chance that there's an elephant in this room is absolutely 0. Then to say rule out is fine. But if you have a patient with a headache and you do a spinal tap and you don't find any blood in the spinal fluid, that does not rule out the possibility that they have an intracerebral hemorrhage, because there are false negative spinal taps for this particular purpose. Some patients with pneumonia have a normal X-ray. I don't know how many, but it's not 0. Almost everything we do in medicine has some significant possibility of false negative. But if we say rule out, it's a natural tendency to understand that that's what it means, because the phrase rule out. So because words influence thought, it's better to say we have considered this, or this study showed did not support the possibility of, rather than say we ruled this out. We need to pay attention to language because it influences thought. It's not only a device for reporting experience, it defines experience. One example here, of course, and there are endless examples of how language is used to frame understanding. Putin didn't say, I'm invading Ukraine. He said, this is special military operation. That's not the only thing here. He also said he was denazifying Ukraine. And I haven't seen evidence for the Nazis in Ukraine. And of course, that's not the topic of this presentation, but it just shows the very enormous power of words can be devised to influence and control thought. And we need to pay attention to that in medicine as well. Lesson number 10. How do I want the students to behave? And if I have to select only a few words, I want them to be fierce, to nurture an intense or ferocious aggressiveness. I'm sorry that my description of many students will be, they're rather passive. They're waiting to be taught. But I want them to be fierce in these two ways, in the pursuit of their own learning and in the pursuit of the patient's benefit. It's hard to explain or to represent, what do I mean? Fierce in the pursuit of your own learning. Fierce in the pursuit of the benefit. Imagine a person willing to go into a burning building to rescue children. This is fierce. We must be fierce in working to help our patients and working to educate ourselves. Experience is not what happens to you. Experience is what you pay attention to. Only those items which I notice shape my mind. And similarly, education is not the filling of a pail, but the lighting of a fire. And it's a job of every student. They have to allow their fire to be lit. And if they sit in the back of the room, you know, a room, we have neurology case conference, and there are 60 seats, and the students sit as far away from me as possible, even though I tell them that I have no infectious conditions, and I'm not going to ask them nasty questions if they sit in the front, and that the seats in the front are the same price as the seats in the back. But their fire can't be lit if they sit so far away that the light, maybe the fire will be extinguished by the time the information gets to them. Because experience is not what happens to somebody, it's what you do with it. The key factor which determines what we perceive, lesson 11, is our attention. So if we're not looking for snakes, we might not notice this. These little fellows, actually 2 snakes. But if you're looking for snakes, you're more sensitive to the sound of them slithering in the grass and the shape that they take when they, of course, when they move. We don't perceive everything. We perceive things according to our attention and how we focus our attention. An important topic here, of course, is bias. And the general principle is everyone has various bias, various forms of bias. It's not possible to not be biased at all. The key factor is to be aware of your bias. A bias of preconceived ideas. If somebody tells you the answer to something in advance, you're not going to be able to think about it in an open fashion. We're all biased in favor of common conditions. Some people I've known only wanted to come up with a diagnosis if it was uncommon because it made them sound intelligent when they said, oh, I think it's so-and-so, and they mentioned something nobody ever heard of, and they were often wrong. I'm impressed with the importance of this bias of the lost actors. So we're learning from our patients, but we don't learn from the patients who don't show up. Sometimes they don't show up because they got better, and sometimes they don't show up because they got worse. Sometimes they don't show up because they died, but we're not learning from those that we don't get to see. A remarkable matter was a study of learning in rats showed that the expectation of learning was expectation of results influenced the performance of rats. on a learning test. What the experimenter thinks can influence the results, not only in humans, but even in animal studies. So the importance of double blinding is very critical. Lesson 13, look beyond the easiest options for your education and pursue the best resources possible. So if you want to specialize in anything in particular, you should try to get the best training, the best experience. If a student has an elective in the 4th year and they want to do ENT and they want an elective, they should consider going to Harvard for a month and do the ENT there, or some other place. Not that we don't have good ENT here, but it'd be good to have a variety of experience. But don't be happy or consider the situation with Solomon Carter Fuller, who was an African-American physician born in Liberia, and he came to Boston, went to medical school, and was working in pathology, neuropathology in a psychiatric hospital around 1895. And he wanted to be trained in neuropathology because he didn't know that much. So what did this African-American psychiatrist, what did he do? He went to Munich to work with Alzheimer, which was in the lab of Kraepelin, Emil Kraepelin, perhaps one of the best laboratories in the entire world. And Alzheimer hired him, and he wrote some of the first papers of about Alzheimer's disease ever published. He had immense courage and foresight, and he looked beyond the easiest options and pursued the best resources possible. Don't forget the assumptions of your techniques. So this Alzheimer paper is famous for having compared smoking in veterans with Alzheimer's disease in non-veterans. So they found that smoking was a risk factor for Alzheimer's disease because all their patients came from the VA and all the controls came from the community. And everybody who's been to the VA knows that the veterans are smokers. That's not a valid, that's an assumption that you need to be entitled, you need to examine if it's a good assumption or not. Lesson 15, you're primarily responsible for caring for the patient, not the family. That doesn't mean you don't pay attention to the family, but it's a rather horrible thing to think about. But sometimes the family would be happy if the old man would die so they can have the boat or the house or the car or the bank account. The most horrible example of this is Dr. Autumn Klein, who was a neurologist in Philadelphia, who got sick at work, went home and had to be admitted to the hospital and died the next day of cyanide poisoning. And her husband is in prison for life. He's been found guilty. He claims he's not guilty, and of course, I have no idea. But this is what was published in obituary in the Green Journal of Neurology. So if you have a sick patient with a concerned loved one, you should not be completely blind to the possibility, at least consider the possibility that they don't have the patient's best interest in mind. Of course, this is very uncommon, but it is, if you don't think about it, you won't notice. Next, cognitive function is relevant for all of medicine. Of course, this is my specialty, so I'm biased. I'm aware of this bias. But imagine a man with stage 3 cancer of the prostate, and the urologist will say, okay, Mr. Tanaka, do you want to do watchful waiting, heating, cooling, ultrasound, open surgery, robotic surgery, radiation beam, so on, or radiation seeds? Which ones? Each one has these advantages and disadvantages. What do you choose? Well, aside from the fact that he may be upset, depressed, and even agitated to hear bad news about his prostate, if he is cognitively impaired, he can't make an informed decision. But you have to know how well his cognitive functions are working. So every physician needs to be able to test this. Actually, every person who has surgery has to sign a consent form, and the consent form implies legally that they know what they're doing. So really, we're not allowed to have patients sign consent for admission or sign consent for surgery unless we know that they're competent to make such an important decision. Lesson 17, and I'm approaching the end, and I'll be very happy to answer your questions. A 76-year-old man he falls, he fractures his hip. What happens? He goes to the hospital, they do an x-ray, they see the hip is fractured, and then they send him to orthopedics. And what if you're there in orthopedics? What do? Okay, obviously you take care of the fracture, you set the bone or whatever, or you operate and replace the hip. That's all fine, but that's not everything. Why did he fall? Did he have vertigo because he's anemic? Was he taking the wrong drugs? Does he have a little cat that tripped him? Did he have a trip over an electrical cord? Was he drunk? Did he have a stroke? Did he have a heart attack, arrhythmia? Was he pushed? Somebody poisoned him. Or, of course, medications. But I guess, obviously, these are all important things that not only does the hip needs to be fixed, but we need to consider why they fell, why he fell. He might go home after surgery and then fall again. This is a bit tricky, but how often do rare events occur? And the truth is, specific rare events occur rarely. So on the left is very large hail. This is a rare event. I've never seen in my own life hail that big. However, on the right is a cherry blossom tree in Japan called sakura. And you could say it's also a specific event which occurs rarely because every tree is different. So specific rare events occur rarely, but everything that happens is a rare event. So I've given other medicine grand rounds. I've never given one on this topic in this way, sitting at home. Every grain of rice is different from every other grain of rice if it was analyzed in detail, considering its ultrastructure on an atomic basis. Because every event is a rare event, the disease is common, the patient is unique, as I said earlier. I want the students to know that smart people make mistakes. I'm afraid the way I believed as a medical student was the faculty knew everything and they couldn't possibly be wrong because they're professors. Especially a chair of a department would be brilliant and would certainly know everything there was to know about anything and couldn't possibly be wrong. But just consider that Galileo, who was undoubtedly a bright guy, Galileo Galilei, he said that the moon was not involved in the tides, which of course is wrong. Tragically, Duke Medical Center in North Carolina gave a heart to a transplant recipient without checking the blood type. And I mean, this is a great tragedy. She died. And this is not rocket science or neurosurgery, so to speak. You know, this is well known for the past several decades. You can't do a transplant of an organ without having the blood type be compatible. And we would all think, oh, something like this could not happen. But it did, because smart people make mistakes. Because smart people make mistakes, I recommend using a checklist. This is a sample checklist for a pilot And this is my checklist for a clinic. So every patient I see, I consider these things before they leave. I don't address them all in each case, but at least I consider them. Most notably, herpes zoster can be prevented with a vaccination. And the patients don't come to see me and say, Dr. Friedland, should I get the vaccination for herpes or not? They just see me for other reasons. But if they're over 50, I feel that if I can help them prevent a neurological infection like zoster, I should do it. So because I have it in my checklist, now I never forget it, because this is the last thing I look at before the patient leaves the room. Before I used the checklist, I had a sign on my wall about zoster vaccination, and that helped me get to about 50% compliance of asking them about this. But everybody can design their own checklist for what they need to be reminded about. Finally, consider further the discussion of ferocity. Louis Pasteur, who was my candidate for the greatest scientist of all time, considering how many things he did, considering he was only a chemist and not a physician. Of course, he wasn't a virologist because viruses were not discovered yet. He said, let me tell you the secret that led me to my goal. My sole strength is in my tenacity. I think this is an important concept for students, because many of them will feel, well, I'm not smart enough to be a researcher. I struggled with calculus, they may say, or I was not the top student in my class. But Pasteur is saying he was so accomplished, not because of his intelligence, but because of his ferocity, his tenacity. Here we go, again, ferocity. So we need ferocity and tenacity, and we need imagination, not intellectual brilliance. That's not necessary. And sometimes it could even be inhibiting. Finally, Paul Feyerabend is a philosopher of science who worked in Berkeley. He said, no theory fits all the facts in its domain. This is remarkably similar to what I was taught by David Clark at UK in medical school in the 70s. He said, we can throw out one fact about each case. He didn't really mean throw it out in the terms of not consider it, but if it doesn't fit, that doesn't mean the patient can't have some disease because one thing doesn't fit, because no theory fits all the facts. So whenever you have an idea, either a scientific idea or a clinical idea about a patient, don't expect everything to fit. So when Randy Marshall in the 60s said that peptic ulcer is caused by bacteria, people said, oh, that can't be because bacteria can't grow in the stomach. But it turns out they do grow in the stomach. So if you said no theory fits all the facts in its domain, that means it's okay. There could still be bacteria causing ulcers, even if we believe that they can't live in the stomach, because that happens to be wrong. Finally, what did these three gentlemen have in common? Alexander Fleming, Prusiner, they all made great discoveries, antibiotics, prions, and vaccination for smallpox. All of them were not first. It's not necessary to be first. It's nice, but you shouldn't be dissuaded or discouraged from working on something just because other people are doing it, or you think it's already been done. That may not be a good approach. Thank you very much. And in conclusion, my basic idea is we need to think about thinking. We shouldn't just allow our thinking to go on without awareness. We can't be completely unbiased, but we can be aware of our bias. Smart people make mistakes. And the first thing to pay attention to, particularly in the days of the electronic health record, is the patient's story. And we can use the patient's story to enhance our learning if we demonstrate ferocity in regard to our own education and our care for our patients. Thank you very much, and I'll be pleased to address your questions either now or by email later. Thank you.
Thank you so much, Dr. Friedland. We do have a couple minutes for questions, and I would like to start us off. Thank you for some really wonderful food for thought. And I was thinking about, those faculty members who will be wrapping up grand rounds in a couple of minutes and walking over to the hospital to round with their teams and take care of patients and teach, and wondering, how can we take this food for thought that you've given us and figure out how to really operationalize it in our day-to-day teaching moments. You offered the suggestion of using a checklist, which I think is wonderful and really jives with the quality and safety literature. You mentioned encouraging your students to take notes. So I wondered if you or your colleagues, you're showing us some, the notebook, have come up with other sort of tips and tricks that we could give to our faculty in terms of, turning these bigger ideas into changes that we make in our behaviors as teachers.
Very good. Yes. I personally feel that it's not my job to teach the students there are 12 cranial nerves. They should already know that, and they can learn that from a book. So if I'm going to have them for a day, I'm hoping I can teach them something that they can't learn for themselves. So I'll try to expand their awareness of their ability to pay attention and of their question of how they make decisions and how they perceive situations.
Thank you. And I want to turn to the chat from Dr. Kruger. We have, how do you address the learners regarding reading? Seems to me up to date isn't necessarily up to date, and moreover, should not be the only reference students and residents use. And her second question is, how do we get students back into the patient's rooms rather than spending so much time on the EMR?
I think students should be reading scientific biographies or autobiographies. So stories about great scientists, then you learn how irrational and non-directional that great people did great things, not because they knew what they wanted to do when they went in a straight line. It's never like that. It's always like that. And I always teach them, if I can, how to prepare the electronic health record. That if they do it the way they're supposed to, the information will be lost. I want them to put everything in the very end in the discussion, where they'll have the findings and the conclusion, and they can't end the note without having a conclusion. They can't just have it stop if they can't have an impression and a plan. And they need help to do that because they have a lot of experience in bad example.
Thank you. Do we have any other questions from the audience before we wrap up?
That is everything.
Uh-oh. Whoops.
That was an interesting question.
Yeah. Oh, Dr. Friedland, I think I accidentally muted Dr. Friedland. I'm sorry.
Right.
There we go.
Oh, there you go. I'm sorry. Yeah. But thank you, Dr. Friedland. It's a great talk as always. And we always enjoy our visit from Neurology each year. And Dr. Cook, is anything that you'd like to, anything you want to wrap up with here? Or?
Well, I'd just like to say thanks again. And I appreciate hearing kind of the more but a somewhat of a scientific view. We have a brain scientist with us telling us about learning. And I love when medical education and experience as a clinician can come together and just really make us think about, and be intentional about our daily interactions with our learners. So thank you, Dr. Friedland, and we appreciate you representing the Department of Neurology this morning.
Thank you. My pleasure. Have a great day, everybody.